program that you've set up, and when I look out here and see
tonight. What I'm going to talk about this morning are the goals and objectives of biological dentistry as I see that. But it's an organic thing, and we'll welcome anybody's input and ideas, so stay in touch. 67 years ago, Dr. William Guise, in his report to dental education, indicated the need for biological sciences in dental practice when he said, expanded as it should be in biological scope and strengthened in all its health service aspects, dentistry, then a learned profession, would be devoted in broad terms, A, to establish the principles, and B, the application in all forms and degrees of scientific health service related directly to the teeth and the closely adjacent oral tissues, and indirectly to the welfare of the other parts of the body and of the whole system. To discovery of the correlations between dental and oral conditions and systemic diseases, with special reference to observed effect in distance disorders on the teeth and closely adjacent oral tissues, and of dental and oral abnormalities on the health of the body, and D, to detection and provisional diagnosis of dental and oral symptoms that indicate the prevalence or imply the probable existence of ill health elsewhere in the body. And of course, we'd like to add to that, we'd like to study the correlations between the teeth and the distant dysfunctions of the body, pain and dysfunctions of the body. To include with, let's see, the probable existence of ill health elsewhere in the body, and to suitable supplemental advisory health service, including consultation with the patient's physician based on such observations and diagnosis. In this view of an enlarged dentistry, its practitioners would be trained to give the service not only of dental surgeons and dental engineers as at present, but of oral sanitarians and oral physicians as well. You know, this whole thing had been gone through in the 20s. There was a stomatological movement led by Alfred Asgius, and they were going to go for a two-tier dentistry, one where the dentist would, diagnosing dentist would be a physician of the mouth, and the other one would be a technical dentist. Dentistry was afraid of that. They wanted to keep it autonomous. William Guise, in fact, in one of the reports he wrote for the Carnegie Foundation, stated that they were in favor of that, but it didn't work out two tiers wise. What ended up was dentistry became autonomous, and I think they did that for economic reasons, so that they have two profit professions, the industry that supports them. And when you look at the history, that's what you conclude. Instead of examining only the teeth and mouth of the patient, they would also suitably inquire into and keep careful records of the state of the patient's health, particularly as it affects or is modified by the conditions of the teeth and mouth. Dentists would plan their procedures to meet not only the local indications, but also the possible requirements of extraoral relationships. Would also recognize and warn or advise of the patient accordingly, or explain his need for a physician's attention, or could effectively discuss with a physician the oral conditions in the relationship to the patient's general welfare. We have a number of double profession type of people here, MDs and I think Dietrich's close to getting his honorary DDS degree. Um, yeah. But he realizes the importance of the teeth and how they contribute to his overall treatment. And we really want to make a plea that next year when we have a meeting, that everyone bring their physician, or if you're a physician, bring a dentist. Or if you're a naturopath, bring a dentist, or bring a chiropractor or a DO, or whatever, you know, but whoever you're working with. And I think that's really an important thing. The frequency with which dentists are and will continue to be consulted for oral health service gives them special opportunity and occasion to note not only the occurrence of oral and systemic diseases, but also the existence of correlations between them, and to help or guide the patients accordingly. Our goal really is to help mankind get rid of chronic oral disease. I think that's always will be the goal, and to help the patient. Sometimes decisions made in organized dentistry go contra to these objectives. They forget why they're doing all of this. I think the expectations that we can expect that, and I hope that biological dentistry will lead to practicing no dentistry. The problem with dentistry is dentistry. As you understand this and get into it further and further, there's not much you can do right because the body says it's wrong. And we have to learn that. So one of these days we'll eventually take that to heart and really get interested in prevention. And we have all the knowledge. It's just the way that we have to present it. We have to incorporate modern telecommunications. We have to present programs where we teach youngsters the necessity of not destroying themselves. We do this socially because we really don't know any better, and it has never really been explained to them. What we need are transponders in the sky beaming down this message day in and day out, like we get the message to buy all of those artifacts and material things and drugs and things that can harm people. I think that's what the expectation is. Biological dentistry will, in fact, become dentistry of the 21st century because it is a depolluting man. And we've made a mess out of it, and now it's our opportunity to clean it up. And I'm certainly glad that you're all here and can participate in this effort. One of the things I would like to say also is that I didn't allow any time for discussion, so I'd like the speakers to entertain some questions toward the end of their talk, okay? So that's good. Okay, Gary, we can start with David. He's going to introduce David, please.
Our next speaker is Dave Regiani, who graduated from the University of Detroit in 1978. Went to practice in Ortonville, Michigan. His wife is really the one that got him started in biological dentistry. She was a hygienist, working for a dentist in a pedodontic practice as a hygienist, and she was involved in the kind of the control program at that particular time. She went to a lot of different classes, studied with Huggins and Lyndon Smith, and I guess probably Bob Barkley. Right. And she kind of would come home and discuss these things while David was plugging amalgams. It wasn't until about 1981 that he decided maybe he ought to look into this a little farther. So he went to see a man by the name of Jess Clifford in Colorado Springs in February of 1981. It was a class on cell morphology. He came away from that class very impressed, to say the least. He came back and had a big yard sale in his front yard of his practice where he sold amalgam caps. He didn't want to dump them in the river, he knew better, but he sold about 3,000 caps at the time. So he really got started again in body chemistry. He was already doing nutrition and that kind of thing, and this was just another step up in his practice to his patients. So in 1983, he was at the big biocompatible dental materials class in Colorado Springs. And by 1984 then, Vimy and Ziff and Regiani, and there were 13 of them, started the IoT at that particular time. He pointed out to me that their first name was the American Academy of Biological Dentistry, but for some reason they changed that to IoT. So he became president of the organization. He's a past president. And he's also now the chairman of the education committee. One other part that you may know, or you may not know about him, is that Doug Cook and Hal Crystal and Regiani have developed a very interesting instrument which they'll demonstrate here at this meeting next door, the OPM number 1. So it's been kind of like, what, about 5 years in process now. And it's an outstanding instrument that has class 3 approval. They have an IRB that they're working on. And so have known Dave for a long time, and he's truly a scientist. He's always looking after his patients and trying to figure out what's working and why it's working and how he can do it better. He's an outstanding practitioner, and we're going to learn a lot from him.
Thank you, Gary. I had forgotten one thing, but it's okay. I'm mercury laden. And Chris, would you roll the video? I'm playing this especially for Gary. I want him to see this. So Gary, you stand out there in the front. I want Gary to be able to identify what's happening to him, possibly in the future, and take appropriate steps to
Guys, it's only vitamins.
Vitamin C, you know, like in oranges.
assembly people and phone ones that aren't even yours and tell them they're not going to be elected ever again if they don't get with it and allow the people to obtain what they want without interference from the FDA. I won't get any further into that. But okay, David.
Good morning. Good morning. We're going to try to make this, we have a lot of things to cover. First of all, I want to say that as far as the title, The Evils of Oral Galvanism, I didn't like that title very well. It should be The Science of Oral Galvanism, The Science of Galvanism, dealing with corrosive chemistry. How I got into this was nobody else wanted to talk about it. So we were sitting around a board meeting of the International Academy of Oral Medicine and Toxicology, and everybody looked at me. I says, all right, fine. I'll do the research. I'll look it up. I'll see what they have to say. And voila, that's what got evolved into the situation I have. I like to hold questions till the end. And if we don't get to questions at this time, anytime during this weekend that you'd like to talk to me, I'd be happy to. Okay? Thank you. Oh, that's an idea, isn't it? Whoop, wrong way. It'd be a good idea if I use this right, wouldn't it? Oral galvanism. Now, this is a translation from the front page of a Swedish newspaper in 1987. We got onto the wrong track from the very beginning due to the emphasis on the so-called oral galvanism, explained the chief of the social sterilization of the Dental Bureau, Hans Sundberg. This aspect, everybody was looking at galvanism rather than looking at dental amalgam. And I thought that this was kind of interesting that they were doing a lot of research back in the 80s on oral galvanism, and it sort of was a never-ending wheel. It didn't really get anywhere. What we're going to talk about today is some definitions of galvanism, the history, sources of galvanic current, types of devices, what you're measuring, the criteria of the device, symptoms of galvanism, biological phenomena in current, lesions in current, decalcification, salivary composition, current and insulators, and a general review. What's oral galvanism? It's a term indicating electrogalvanic current created between metallic restorations in the oral cavity. Corrosion is an actual deterioration of a metal by reactions with its environment. Classification of corrosion, there's two types. Chemical, which is direct combination of metallic and non-metallic elements, and electrolytic corrosion, caused by a flow of electrical current. Electrolytic corrosion, there's two types of that, both dry and wet. Wet is what we see in the mouth. Different types of electrolytic wet corrosion. You have it between dissimilar metals, heterogeneous compositions, and homogeneous surface structure and concentration cell or pitting. The electromotive force, that's the potential difference between the poles of unladen electrical sources and its terminal voltage, which is the tension between the poles of a laden electrical source. Isn't that interesting? Does anybody know what that means? Basically what it means, and I'll get to this next slide, is you have different metals with different electrical charges. Some are positive or cathodic, others are negative or anodic. And you have combinations of these metals in the mouth. Therefore, what happens is when you have combinations of these different metals in the mouth on different restorations, you have different potentials. So the difference between one metal, let's say on tooth number 14, and another metal on tooth number 12, is your electrical potential, or your difference. That's what it means. Now it's simple, right? History of oral galvanism. It actually started in 1957 by Sulzer, who placed two metallic objects in the oral cavity and noted that upon contact, a taste sensation could be perceived. This perception was interpreted as an evidence of electrical activity. In the 1870s, discussions of oral galvanic action and its influence on oral health appeared in association with the introduction of a new plastic filling material, such as amalgam, the so-called new departure. In the 1937s, reports were made suggesting that electrical irritation effect produced by some combination of metals used for filling teeth and constructing other dental restorations was a possible factor in the production of precancerous and cancerous lesions in the oral cavity. However, simple electrical measurements simultaneously reported did, however, show no connection between the amount of current measured and the severity of the symptoms. One of the problems with galvanism in trying to show a correlation or a relationship is that you can have some people with all kinds of electricity in their mouth and no symptoms, and other people with hardly half that amount with all kinds of symptoms. What's the answer? How do you measure it? What you're looking at? In 1952, a possible connection between oral galvanic activity and biological reactions was studied. Shriver and Diamond, physicist and a physician. In 1957, oral biological phenomena as a consequence of electricity was presented. In the 60s, virtually all attempts to qualify oral galvanic action were based on the measurements of the differences in potential between oral metallic objects. Nobody was looking at current. In 1962, a study of possibilities to electrically stimulate teeth concluded that measurements of oral potential differences can only be satisfactory provided adequate steps be taken to control resistance. That's something that deals with the machines, and what one machine may be good, other might not be telling you anything. So therefore, you're not getting a true picture of what's going on in the mouth. Around the 70s, a number of studies on various types of biological reactions to dental materials began to appear. And also a number of studies were reported of experiments of a galvanic action engaging metallic materials. Now, different sources of current. Phil, we need the overlay. We have 3 possible sources of electrical current that exist in the oral cavity. We're going to be able to do it? We might have a glitch here. Anyway, we have electric cell formed between the 2 fillings via the saliva. You have an electric cell formed through the bone fluid, and you have a liquid junction cell. And I'm going to illustrate what these 3 are in just a second. Does it turn on somewhere? On the top. Nope.
Oh, here it is.
Yeah, great. Okay. Can we turn that off for a second? Thanks. So, this here is measuring between 2 metallic objects. Okay. Okay, next. A ground in the floor of the mouth, and also measuring then the different metallic objects. And thirdly, a galvanic cell, where you're measuring from the top of the restoration down, and this does not illustrate as well as I'd like it, down to the apex of a tooth. So different ways you can measure metallic objects. So you can get all kinds of different readings. What are these readings telling you? What are you looking for? That's what you have to understand of what you're doing with an instrument and what the instrument is trying to produce. Okay, that's good. Thank you. I think we'll go back on the slides here. Whoop. After we turn it on. Okay. Types of devices. What types of measure devices are used at this time? We have the amalgameter that, I don't know if any amalgameters are still around, they may be. You have potentiometers, oscilloscopes, the EM202, and numerous other apparatuses such as the oral potential meter that we have on display this weekend. What are you measuring? When measuring the oral cavity, we must measure both current and resistant, or the potential difference, to get a true picture of the oral galvanic situation. The overlays again? So we have development of electrical potential depends on the constituents of the metal alloy as well as on factors of the oral environment. We have differences in electrical potential may play an etiological role in the development of oral leukoplakias and lichen planus, and we'll get into that. And electrical currents may be responsible for phenomena of oral galvanism with symptoms attributed to it in the oral cavity and elsewhere in the body. But again, you need to look at both. You can't just look at current, and you can't just look at electrical potential. Okay. Whoop. Could you catch that, Mark, instead? Thank you. The criteria of a device. According to the literature, in order for us to understand in intraoral currents, the apparatuses used to measure these currents need to be reproducible in their values. Again, if you're going to use a device, make sure the device tells you the same thing every time. I've used some of the devices that I had displayed on the screen previous, and I would not get reproducibility. That was one of the reasons I got involved in coming up with an apparatus such as we have. The symptoms of oral galvanism, and there's going to be a sheet that's, I don't know if Carol Arana has passed it out or not, but I have 3 sheets that are going to be available to all. One's on the symptoms of galvanism dealing with the patient, the practitioner's observations, and thirdly, a sheet that we use to register our readings. But in 1936, objective symptoms, and I'm not going to get into these because these are on the sheet and they're a little more, they're more simplistic on the machine. It's a nice sheet to use in your practice if you have any concerns about these things and find out a little bit about your patient. It'll take your patient 30 seconds to a minute to fill something out. But you're looking at disintegration, discoloration of metallic restorations, dental cements, the mucosa, looking for erosions and ulcerations, leukoplakias, etc. And the patient has certain things that they experience. Metallic or salty tastes, an increase or a decrease in salivary secretion, burning sensations of the tongue or of the palate. Okay? They could have warmness around the fillings, like a warm feeling. Just a number of different things that can be looked at that could be dealing with the electrical activity in their mouth. But before you make a final diagnosis, you have to look at all different aspects as well as measuring. Electrical galvanic injury to the oral mucosa is made. One should try to eliminate the possibilities of fungi or Vincent infections and skin eruptions such as syphilis, lichen planus, herpes, erythema multiforme, lupus erythematosus, gastrointestinal or blood dyscrasia, which may cause similar lesions on the oral mucosa, or medications. How many times have we seen medications may have some impact? How they have an impact may be very interesting, and I'll get into that in just a minute. Are there any relationships between intraoral galvanic current and systemic symptoms? Brun et al. Demonstrated in rats that different compounds of various amalgams could be transferred to the blood system after gastrointestinal administration and accumulate in kidney and lung tissue. Well, let's have some amalgams and other metallic restorations in our mouth, and where do they go? Suzuki reported that gold, platinum, and palladium were not harmful, while silver, zinc, and chromium formed granulation tissue to some extent and caused active formation of fibrous tissue. Various kinds of corrosion products which are released from metallic dental restorations can penetrate into hard and soft tissue. The saliva, and via the saliva reach the gastrointestinal tract. The remains of these corrosion products, which are not excreted, are then further distributed to the various parts of the human organisms, sometimes reaching specific target organs. This was done in 1978 by Bergman and Ginstrom and Milner. Does the condition of the oral tissue, before I get to this, Phil, could you put those overlays up? One of the things Ed asked me to do, he says, kind of get into some homeopathic things. So maybe you could look up some different signs and symptoms dealing with different metals used in dentistry. And so I went to the Materia Medica Boraces, and I start putting down some of the different symptoms related to these metals. This is metallic gold, aurum metallicum. Attacks the blood, glands, and bones, conditions bearing striking resemblance to mercurial and syphilitic infections, states of great depression, great desire to commit suicide, exostoses, arterial sclerosis, sclerosis of the liver and the brain, oversensitive to noise, and extreme photophobia. A little farther down. Yeah, we have copper, spasmodic affections, cramps, convulsions, beginning in the ears and fingers and toes, tonic and clonic spasms, convulsions, nausea, metallic slimy taste. Okay? Could that be the reason of galvanic activity, of that symptom of metallic taste, okay, or salty taste? We have argentum, silver, emaciation, gradual drying up, dyspnea, chief action on articulations and their component elements, bones, cartilage, and ligament. Involuntary contraction of fingers, swelling of the ankles, severe backache. Next. We have tin, the chief actions on the nervous system and the respiratory organs. Pains that come and go gradually. The mind, head pain that increases and decreases. Colic relieved by hard pressure, extremities, paralytic weakness, drops things, limbs give out when attempting to sit down. From tin. Well, where do we find tin? Tin. We find it in metallic restorations, in amalgam, in cast alloys. Mercurius. I threw this in, and we don't know enough about mercury, right? It affects healthy cells into decrepit, inflamed, and necrotic, I love this, necrotic wrecks. Decomposes the blood, producing profound anemia. Lymphatic system is especially affected. Tremors. How many of these things have you already seen related to the nervous system? Okay. Again, we don't know, and I'm not going to sit up here and tell you what this galvanic activity may or may not be doing, but it's something we need to look at in that relationship. Excuse me. We have nickel, periodic nervous, sick headaches with asphonia, weak digestion, constipation. Nervous literary patient with frequent headaches, dyspepsia, and constipation. Migraines, first on the left side. We have alumina, general conditions, dryness and mucomembranosus skin, tendency for paretic muscular states. Palladium, motor weakness, adverse to exercise. I guess a lot of us are that way. Platinum, strong tendency paralysis, anesthesia, localized numbness and coldness. Okay. Again, if you've looked at anything from a toxicological standpoint, you have to consider, at least in this relationship, the synergistic effects of metals. We don't know enough about them. There's a little bit of, there's a lot of information out there, but looking at this synergistic effect, this is what we're looking at. We have cobalt, adapted to neurasthenic spinal states, fatigue, agitation, bone pains. Indium, headaches, migraines, backaches. Iridium, could you bring that up a little bit? Epilepsy, lupus, rheumatism, gout, spinal paresis, exhaustion after disease. Next. Thallium, influences endocrine glands, horrible neurologic, spasmodic shooting pains, paralysis of lower limbs. Titanium, found in bones and muscles. Lupus and tuberculosis usage externally. Skin diseases, nasal catarrh. Again, I just wanted to review that and show you the situation at hand. Thank you. Does the condition of the oral tissue change after dissimilar metals are removed? This was a summary of a paper by Benosic et al. Considering the results of treatment, the complete removal of different metals by placing composite fillings or by extracting the teeth seems to be the method of choices in cases of electrogalvanic white lesions. Okay, and I'll show you what we're talking about. They did a study and they took, I think it was a total of 32 patients with 36 locations or lesions. If they did 4 different methodologies in regard to getting rid of these electrogalvanically induced lesions. They had 20 cases where they changed the metals only. In 13 of those cases, they had disappearance of the lesion. In 7 of those cases, they had regression of the lesion. If you extracted the teeth, all the lesions went away. That was an easy way of doing it. If you changed the metal plus you surgerized the area, you can see of the 5 situations, 2 of them went away, but 3 progressed into carcinomas. If you surgically excise the area without changing the metal, you got pretty much the same results. Now, with an apparatus, with a galvanic apparatus, you have the ability to measure these situations and to see if you can conservatively eliminate a lesion. Okay, and we'll be able to, like I said, if I don't get to it today, we'll be able to demonstrate to you with Doug or myself with our apparatus to show you how you can conservatively do things like this. And you do see this. It was funny. As soon as I came out with this, we came out with the machine, I had 2 cases walk into my office within a week. And I used the apparatus to conservatively treat a situation like this. Considering the results of the treatment, the complete removal of different metals by placing composites or by extracting the teeth seems to be the method of choice. Well, at that time it may have been, but again, extracting teeth, that's pretty hard. Okay? People don't want to do those sorts of things. So what do we end up doing? Cutting the lesion out, and half of the time it came back? Does the condition of the oral tissue change after the similar metals are removed? Various kinds of corrosion products which are released from metallic dental restorations can penetrate into hard and soft tissues and via the saliva reach the gastrointestinal tract. This is the same slide I had shown you earlier. Yes, it can. Suzuki reported that gold, platinum, and palladium were not harmful. Again, the same thing I showed you before. We'll go by this. Okay. Are there any relationships between intraoral galvanic current and systemic symptoms? Yes. Oh, where are we at? We're going backwards. Sorry, guys. Yeah, I was. Huh? Yeah. Okay, dealing with these chronic parallel with Bonosik and Bonosik and Ove found that a parallel cannot be drawn between the severity of registered chronic oral damage and the magnitude of potential differences. The subject's individual endurance and constitutional reaction play an important role. The decline in the organism's defensive reaction may lead to the manifestation of various symptoms. The time factor is to be regarded as primarily important since the unfolding of complaints takes considerable time. Sometimes years pass until a definitive clinical entity develops as a result of damage caused by potential differences between replacements. The same applies to changes in conditions following the removal of metal replacements. Basically, what are they saying here? They're saying that there's all kinds of situations that can trigger this mechanism to occur, this galvanic activity to occur. That's it in a nutshell. Contact allergy may play a pathogenic role in the development of oral neoplasms as induction of chronic inflammatory changes leading to neoplastic changes. Other well-known factors such as smoking and Candida albicans infection may play the role as promoters. The mechanism by which these pathological changes are induced is uncertain. The present case indicates that contact allergy to metallic compounds released by the action of electrogalvanic microcurrents could be of importance. This is Suzuki in 1960 showed the effects of metals embedded in oral tissue upon the tissue itself were investigated in the adult dog using gold, platinum, palladium, silver, zinc, chromium, aluminum, tin, copper, and nickel. And again, fibrous tissue and granuloma tissue was found. Does decalcification occur between restorations in the tooth? Well, Shimamura found in 1958 that if you just had 14-karat gold, you found no effect. But amalgam decalcification was evident in the surface of the cavity wall in contact with the filling. Amalgam is electronegative and calcium ions migrate together with metallic ions of amalgam. Has anybody ever seen having a gold crown and having an occlusal amalgam adjacent to that gold crown, and after a period of time you'll get a lesion in that contact between the two? That's what's happening. Okay, what's happening there is if he's talking about calcium ions migrating together with metallic ions of amalgam. So you're losing the amalgam ions. You're also losing the calcium ions between the contacts. So if you've got the gold crown, you've got an amalgam adjacent to it, an occlusal amalgam, and through the years, if that's placement like that, you're going to end up with a lesion in that proximal contact. That's what happens, and it happens because you lose calcium ions. It's a galvanic thing. It's not necessarily why Johnny or Susie didn't brush or they ate the wrong things. It's galvanism that's occurring. I just saw 2 of those this week in my practice. Does saliva have any effect on intraoral electrical currents? The concentration of protein, sodium, chloride, and phosphate in the whole saliva of the patients with symptoms were significantly higher. The concentration of calcium, magnesium, and IgA were lower in the asymptomatic patients. In parotid saliva, too, protein, lysozyme, and calcium concentrations were significantly altered in patients with oral symptoms. This could lead to passivation or activation of the surfaces of the metallic restorations, and consequently to the onset of intraoral electric currents. Okay? So, how does this occur? This occurs by diet. This occurs by medication, that you can alter the salivary content, therefore leave a patient in a situation of having galvanic symptoms. Okay? One of the things that's been done shown in the literature, they always a lot of the Swedes, getting back to my first slide, they were on the wrong track. They're looking at this aspect and they're blaming the medications or a structural problem dealing with why these people have galvanism. Okay? What it is, it's a consequence of these medications that are causing the galvanic activity by altering the saliva, altering the body chemistry of these patients. Do insulators have an effect on electrical current? Phillips et al. Measured the electrical conductivity of dental cements and found that dental cements had a little effect in minimizing the current transmitted to the pulp. They also found that the cements had good electrical insulating properties when they are dry, but they lost their advantage when they became wet through moisture of dentin or marginal seepage. Moreover, they found that cements induce the quantity of current as they alter pass through the tooth. So, if you're going to use an apparatus in a galvanic cell situation, you can measure the current by placing your ground on the top of it, top of the restoration, and taking the measuring point on the apex and see what type of current. If you don't see anything radiographically, okay, and you percuss, et cetera, another way of looking at why this person may be having pain in a tooth could be due to this breakdown and leakage underneath the restoration. Galvanic contact between two metals where the cathode is larger than the anode usually enhances the corrosion of the latter. Amalgams inhibit the greatest current density of all alloys commonly used in the mouth. It has been reported that its current density is influenced by the mercury content and in the method of condensation. For this reason, electrochemical studies in the oral cavity have been mainly concerned with dental amalgam. All right, we'll pass this up. How am I doing with time? 10? 10 to. We'll pass that up. Okay. Some literary recommendations, just what some of the different papers have to say about metallic restorations in the mouth. In order to minimize the risk for generation of clinically significant current between dental metallic restorations, those in contact should therefore, as long as possible, be made of the same or similar type of material. Isn't that interesting? The majority of research works assume that every effort must be made to avoid exaggerated electric galvanic current until the situation becomes clear. Notwithstanding that amalgam is considered to be useful restorative material, it has the lowest electrode potential among dental alloys, and the effect of this should not be disregarded. According to the results obtained in the present study, contact between chrome cobalt construction and amalgam, as well as between stainless steel and amalgam, should moreover be prohibited. All current standards for dental amalgams, which form the basis for certification testing of the products, lack any testing or requirement concerning corrosion of materials. Work is going on to establish the methods and requirements for such testing, but progress is hampered by lack of sufficient basic data. That's one of the things I found. This was 1985 by Milner, who did a lot of research in this area. We don't have the information to really study this. We don't have the apparatuses to study this. Most of the apparatuses used in these research papers were apparatuses that they put together or were used in other types of endeavors, not for oral cavity. Okay. This just shows the effect of temperature changes on galvanic current. You can see that galvanic current is much higher when you change the temperature with unpolished gold, polished gold, and you can see that amalgams are much lower that particular way. Fillings under crowns of which the dentist is ignorant may considerably influence the electrical behavior of the crowns. Of primary significance are cases in which crown and filling are not in galvanic contact and the cement acts as a secondary conductor. In such cases, the crown functions as a separate galvanic cell. That's what I was talking about, the galvanic aspect, putting a ground on top and measuring to the apex and seeing what the current involved is. Okay? Till in Germany found that the bone surrounding a tooth, if there was no restoration in the tooth, you'd find approximately 0.5 parts per million of mercury. If you had an amalgam in that tooth, you'd find up to 10 parts per million of mercury. And if you had a gold crown over an amalgam restoration, you'd find up to 200 parts per million of mercury. What's happening? You have a cathode and an anode underneath, and it's plummeting these ions into the tissue. Gold and amalgam placed in contact in the oral cavity will cause galvanic currents and increase corrosion in the amalgam with release of metal ions. The corrosion in the amalgam may reduce its strength and cause increased marginal breakdown of the filling. The electric currents and possibly all the release of metal ions may cause oral discomfort in certain individuals. Low values for polarization resistance in a restoration may be a sign of high electrochemical activity. This can often be useful in clinical screening of patients with oral symptoms. Again, why have a device that can look at this? For these purposes. Okay? We have to have something, some facts to base what we do on. And that whatever type of apparatus you have, just make sure the apparatus is, like we said before, reproducible and gives you some stability. If you measure with the apparatuses one week, measure again the next week. I had a problem with some of the apparatuses I use. I'd get different readings, different polarities, different readings, a lot of different aspects. One of the things with the apparatus I have now, I don't find that. I get reproducibility. So I've got some basis to work on that I feel comfortable with. Am I? Okay. Okay, that's it. I have the other overlays I have. I'm going to just briefly go over a case and how I use the apparatus, my particular apparatus. We have this is one of the pages you get. This was a 77-year-old woman on a lot of meds. Again, they felt that the medications weren't causing any of her problems. Okay? I believe it changed the salivary content, which leads to her having these symptoms. And she had metallic taste, salty taste. She'd have an increase in saliva sometimes and a decrease in it other times. She'd have burning sensations in the tongue. She had ringing in the ears, warm feeling in the gums near a filling. Okay? She had a number of symptoms. She said, just tear my teeth out. I can't handle it anymore. What I found is I found disintegration and discoloration of metallic restorations, what we see all the time. I saw erosions around her tongue, denuded patches or geographic linguae in the dorsal area of the tongue. Okay? She had a total of 11 restorations, and she had 8 crowns, and I don't know what the types of golds or the non-precious metals that were in her mouth. But this is the types of readings I got. What I look for with using the apparatus we have is I look for the largest metallic restoration in her mouth, and it was a bridge on the upper left. I then use that as my ground, and I measure the galvanic activity of all the other restorations. On the upper right were 2 amalgams, so we got readings of 63 and negative 0.13 and 63 and positive 0.17. Again, why do you get 2 different readings with amalgams? It depends on the surface and what the surface is exhibiting. Okay? We then took a second reading, and the second reading showed, using a bridge on the left side, that was 4 through 6. We then read everything again, and you can see how the level went up tremendously on tooth number 2. It went up to 130, twice the electrical potential difference. Again, we're talking about the composition of the restoration and what type of difference in potential that we had there. Yes?
Explain why you went to bridge 4 to 6 on your second.
I went to bridge 4 to 6 because my highest readings, let's say if I had a case where I had 110 on 2 different restorations, then I would use current And thirdly, then I would use the wattage as my criteria, which one I would use as my ground going through the second series. And I'm using this in the situation of not tooth pain, but this is dealing with burning sensations, dealing with salty taste, metal taste, etc. With tooth pain, this is bimetallically. With tooth pain, I would use galvanic cell testing and test it that particular way. Or muscle pain. You could have a person with muscle pain, head pain. You can take, with our apparatus, we have a pad that you can place on that area and then measure the restorations in the mouth and see what type of current is being produced going to that area of the head or of the body. Okay? So in this case, I recommended to the dentist who was seeing her a conservative approach to try to eliminate her problem instead of just taking everything out of her mouth because that's what she wanted. So I recommended to him to remove the amalgams on the upper right, 2 and 3. I said, if that doesn't work, I said, the next thing to do would be to remove the bridge 4 through 6. Because if you notice, we have a lot more electrical activity using that as our ground than we did using 11 through 13. And this way, you're much more conservative in what you're doing. And I think the patient will far more appreciate what you're doing than just wholeheartedly saying, we're going to get all these amalgams out and we're going to do this, we're going to do that. Don't do that. People are not necessarily interested in that. Okay, next one, Phil. This here, I brought this along. This is a man that I just saw a couple weeks ago that has paralysis of the lower limbs. And I'm using this as just part of what I'm looking at in regard to his situation. Two things I look at with any of my patients. I look at, first of all, if one I'm going to replace or take out of their mouth, I want to put something in that's going to be less bioreactive. And secondly, I'm looking for chronic infections. Okay? But I also have to look at the aspect of what type of galvanic activity are we producing. And you can look at what we've got going here. Now our criteria basis is, what we start as normal is 10 millivolts, 1 microamp, and 0.01 microwatt seconds. And we used, he had a bridge on the lower left side there, and you can see the readings. And then we found that the highest readings dealt with tooth number, it says 21B, but that's at least 22 buccal. And we used 22 buccal, and you can see that everything was negative. And then we used the amalgam as our ground, and you can see how the galvanic activity went up. Now for every amp of current that we're reading, we're releasing 3 times 10 to the 12th power number of ions out of those restorations per second. That's a lot of ionic activity. What's it doing? How is it affecting this patient? We know that people that have MS have 8 times more mercury in their cerebral spinal fluid than people who don't have it. Why is it going to them? What's it doing to this particular man? I don't know. Could you throw that pan up there? We'll see if we can, maybe, well, we won't be able to do that. This is what his panoramic x-ray looks like. And you can see he has, up on the upper left on 15, he has an endodontically treated tooth that the crown fell off. On the lower right, he's got a, pardon me? Yeah. On the lower right, he's got an endo. But then on the lower left, you can see he has an endo on 20. But look at the lesion on where 19 is. Okay? But what do you do? Do you go and clean that lesion out? What do you do with the rest of the things in his mouth? What do you do with the galvanic activity? If you clean that lesion out and you've got that much electricity going on in his mouth, is he going to heal? That's some of the questions I have. I don't have the answer, but these are some of the questions I have, and I've got ways that I've been going about doing things like that, and I've gotten some success. I'm not going to tell you, like some people, that I've got 80% success if I do it this way, or 90% if I do it this way. I think that's poppycock. I want to say one thing on sequential removal. I couldn't find anything in the scientific literature dealing with sequential removal, and it may be something that's important. But again, look at the apparatuses that you use in regard to sequential removal, and the reproducibility of this apparatus, and really find out what it's really telling you. That's how I feel about that. But this is a rather interesting situation. Right now I've got his wife reading 4 books. Until she ends up reading the 4 books, we're not going to do anything. Okay. Thank you. Any questions? Back in the back.
What's your experience with what you're doing with tinnitus?
With tinnitus? I've had some success with tinnitus. I've galvanically measured the mouth, and I found relationships with that, okay? But not every time. It just, and you just got, and you know, you'll go and you'll find a really high reading, and you'll take that out, and then boom, you'll measure again. You'll go through the mouth, and with our apparatus, we can measure in 5 minutes. We can measure the whole mouth. With having an assistant next to us, we can check that. And just go and conservatively look at that and explain to the patient, you don't have the answer, but this may have some type of relationship. But I'd say, I'm gonna go against my word a little bit. I'd say 50% of the time, I've had reduction or disappearance of the situation. Yes, Chris?
Hey, let's say you have a patient like the one you just presented that has a paralytic problem secondary to galvanic discharge.
Yes.
And you get, let's say you want to do some anesthetic confirmation, local anesthetic, like you would over a bone cavity.
Yeah, I haven't done that yet. I've just seen this patient as an initial patient, initial exam, and we've talked about it. Like I said, I gave his wife 3 or 4 books. I said, read these and we'll get into it. But yeah, that's something I'm going to look at with him.
Well, let me just pose it generally. Do you think that anesthetic confirmation works when you have a focus from galvanic discharge?
Yes, you know why? I think sometimes it does. I think it does if that galvanic activity is not affecting that patient. If their system's that off. On the other hand, if it is affecting, then you're not going to see what you really want to see. That's how I look at it. And you have to go and they have to consider if they're going to remove things and replace things, etc. Then you got to look at it from that aspect, and then again do your confirmation with the anesthetic. Yes.
One thing I thought I might mention that everybody here might want to play around with a little bit is in our practice, actually for a number of years, we've used heavyweight copper bracelets such as this.
Uh-huh.
And from studying the acupuncture meridians, the drainage for the teeth areas are the arm channels. It appears as if you do kinesiological muscle testing, if you put these heavyweight copper bracelets or relatively heavyweight copper bracelets on the wrist, many of the teeth symptoms disappear, and a lot of the muscle testing is stronger. And you can use that temporarily while you're undergoing however many months it takes to clear your patient. But this will give many patients a feeling of well-being while they're trying to find the money to pay you for all the dental work.
That sounds great. You know, whatever works. You know, sometimes you know, who cares how it worked? Whatever works. Okay, and you got to look at it that way sometime.
Well, it appears as if because the meridians are very electrically active, it conducts electricity, the electrical jam, if you want to call it that, away from the mouth area and out down through the meridians. One theory.
Yep. Any other questions? Yes, Terry.
I was wondering if there's anyone else done any more studies about, you know, Hal Huggins in his book, It's All in Your Head, quotes Bowles. And Bowles says that 6 microamps of current will affect the acupuncture meridians. And
In actuality, I remember Fritz Kramer, who worked with Vol, and he used the criteria of 2 microamps.
Okay.
Anything
Is
over
there any-
1.
Did you find in your research any studies that have been done in addition to what Bowles done on that?
No. I haven't read everything. You know,
And I'm referring to the Odon chart.
I know what you're talking about. Yeah. Who knows what that means? Who knows what this electrical current has on that? Okay, that's another way of using an apparatus like this with the EM202 or the oral potentiometer. You can measure that, and Fritz Kramer, who was first came out here in 1986, talked about you need to look at that galvanic activity first before you look at the teeth, because it could be just that release of ions. Yeah, Phil? Oh, okay. Any other questions? Yes?
So what do you tell people who call up and say, you know, can you remove these amalgams just like I read in this book with Huggins' technique of sequential removal? I get phone calls routinely like that. What do you tell them?
I tell them how I feel about it. I don't tell them. how do I feel about it? I tell them, I don't believe in that, okay? I haven't seen any difference in that. There are some dentists who, I really feel the reason, you got to stick to your guns with things. When I got into doing composites and throwing away my amalgam capsule, so to speak, I lost a third of my patients in my practice. I stuck to my guns. I stayed with my beliefs, and that's the way I did it. Okay? I know there's some men here that says, well, if the patient wants me to do it that way, I'll do it. That's fine. If that's how you want to do it, fine. I just say, there's no concrete evidence to show that there's a relationship that way. That's how I feel about it.
It seems to me you are using sequential removal.
I didn't talk about sequential removal. I talked about looking at the galvanic symptoms. Okay?
And you remove the ones that you feel that are creating the most electroactivity.
Yes, but I didn't go along with polarity. Okay? I wasn't looking at polarity as much as I was looking at just
So
the...
So you're kind of using semantics. I mean, it's his philosophy on polarity versus yours on high electroactivity, whether it's...
All polarity is showing is which way it's flowing.
Right.
That's all. Okay? And if you're going to use, again, with an apparatus, I think if you're going to do it that way, then you should do a galvanic cell reading rather than a probe into the floor of the mouth and reading it that way. What's the resistance capacity of your machine that you're using?
I
Okay?
think you're right.
That was my problem with some of the machines.
But I think you've created a sequential removal. It's just a different approach.
Possibility, but again, we need to research it, and that's one reason that we're doing with our machine. We're doing an IRB with Western New England College. We're first of all getting a machine out here in our community to be able to use and reproduce certain situations and be able to get readings. That's all this thing's doing, is showing you readings. You as a practitioner will use those readings accordingly. That's what I'm hoping guys buy the machines and start getting these things. We get more machines and maybe better machines. That's what we're looking at. Yes, Gary?
Are you using this IRB or anybody that's working with you? Are they like removing the fillings? I mean, checking, say, the acupuncture points, say you're working on the
No,
lower-
we're not doing anything like that. All we're doing is we're just turning our information in. We get readings. We turn the information in. We may put down the symptoms the patient has, etc., but we're not following through with treatment at this point. All we want to do at this point, all the FDA cares about, is if the machine is safe and effective. Doesn't hurt the patient and effectively measures the activity we're talking about, just like an EKG machine or an EEG machine. Yes,
Would you
Doug?
find-
What's that?
find-
Do I find a relationship?
Well, no, what I want to throw out to you that you may want to consider, I mean, I know you're not getting paid for doing this, but is to do electroacupuncture testing, say, on the, a Cromer testing or, traditional testing on a lower distance, and then take out the filling, go back and measure.
I'll let Doug Cook will be speaking, I think, later on this weekend, and I'll let Doug Cook talk to you about that because he's one of my partners and he uses electroacupuncture for 15 years now, and he has an apparatus, so he's measuring these things, and he can tell you from his clinical observations. Doug, you have something to say?
Well, in regard to your comment on sequential removal, actually, if you reverse the probes, it also reverses the polarity.
That's right. Well, that's what I showed. I think if I showed you that overlay on that one patient, the last patient, you could see that everything was negative. All of a sudden, everything went to positive. Or actually the other way around, positive and negative. So that was just showing you the flow, period. Doesn't tell you anything else. That's what you got to look at. I wish there was some things that people say, they got to substantiate it with some science. That's what we're here about. We got to do science. If we don't do science, we're in big trouble. Yes?
It seems to me in Chicago, maybe I heard Jess Clifford make a comment on why that worked, and I didn't understand it, but if he certainly might comment on that.
Yes, we can probably get Jess to comment on that. Yes, Dwayne?
Were there more handouts? They didn't get down this way all the way.
Carol?
Yeah, they're right here.
They're down here. Okay. Carol has them.
How many handouts are there?
There's three.
Got one.
There's three.
Dave,
Pardon me?
I want to make a comment about what Huggins says. The positive negative current to some degree with his device depends on the mobility of the probe that you're using. Secondly,
What he says is that if you don't take the fillings out in a correct order, you could fix the patient in ill health for the rest of their life, which means that if I don't do the work the right way, the way he says it should be, that I'm responsible for their ill health, which is a real shame, because what about before the patient even came to you and they had an amalgam placed by somebody, or 5 years ago, or 10 years ago? If he's right, anyone could have done it, but to lay that on you if you don't take them out sequentially, that's a major problem. And the last thing is he even says that in some cases you have to take out the positive current first. I think it's in 1% of the cases, but he doesn't even know which ones those are. So when you look at some of the statements he's making, one of the, there's some real inconsistencies there. And what the patient grasps, though, is they can understand positive and negative. And so emotionally, they hang on to that.
One of the biggest things, thank you, Phil. One of the biggest things in a galvanic or a machine that measures electricity in the mouth is showing you is another way that these metallic substances are released out of these restorations, period. You can measure with a vapor analyzer. You could do salivary contents of the metals, such as Jim Massey has done and shown with mercury at least, that mercury in saliva most of the time exceeds EPA drinking water levels. Okay. He just finished up a study showing that if you drink alcohol that you release upon an amalgam, you produce ethyl mercury. Okay. So, there's so many things going on. We just have to start looking and observing and putting these things together. And these types of meetings, such as what Ed and Gary put on, are where we're going to learn information. Yes, in the back.
Just a little comment. An area bordering on electrogalvanism. Electrogalvanism for us is that you have an electric current flowing between two dissimilar metals, and then all the sequelae of that. But there's another phenomenon that we observe. If you have two dissimilar metals and there's no current flowing, what you have is a function of what in physics is called a capacitor, which generates, without the current flowing, huge electric fields versus magnetic fields, huge electric fields, which affect the brain significantly. So we find a lot of minimal brain dysfunction, insomnia, lack of concentration, those sorts of things with dissimilar metals that cannot be assessed by measuring the current between two teeth, but simply that are established between the voltage that's present between two materials. Because sometimes, because of the conditions of the saliva, lack of minerals and so forth, there's no current flowing. And then you have the problem with huge electric fields building up in the mouth that are completely asymptomatic in terms of clinical symptoms, but they interfere with the brain function.
That's interesting.
Just wanted to alert everyone
Yeah.
to that.
Because you do see that when you get readings. I've gotten where I've got an electrical potential reading, I get no current, and I still get a wattage, and you wonder, says, what the hell? I didn't even get one microamp, and yet I've got an electrical difference of 350 millivolts.
Ask those people how their brain is doing, and they find the answer to that.
Very good. Yes.
In light of what he just said, then why would you want to try to select just one or two amalgams to take out? Seems to me you want to wipe everything out of it.
That's right.
David, I've talked to Al about this, and we kind of just left it. What it is in practicality, you're basically doing a polymer removal at a time. So you're in effect selecting the one with the most electrical activity, and then you proceed that way. And that's basically what he ends up with too. I think the point that Phil mentioned, putting on a bad rap is really kind of the wrong thing, because those other people out there, the other dentists that aren't here, are in fact doing nothing about it. At least we're willing to take a look at it. The electrical activity also takes and activates enzymes, so it's affecting everything in the body. The Swedes tend to support what Dietrich said. They put splints in the mouth, and people's TMJ and headache problems go away, and it's because of the contact, irreversible contact.
Right. They talk about that. A lot of the papers dealing with that talk about that aspect.
Important thing is that these metals dissociate into the ground substance of the body
good point, Ed. Good point. Yes, Chris?
I have Peter's statement. Tell him about the case that you had several years ago, the young lady that had 2 anterior bridges put in that were non-precious metal. Remember her? She tried to commit suicide.
Gosh, I don't.
You had a patient when you worked there. She had some anterior bridge work done, and she told the dentist to make sure to use positive.
I haven't used enough N-acetylcysteine, Peter. I can't remember.
Dave had a case probably 6, 7 years ago that always sticks in my mind. A young gal came in to see him because she was having problems, and the only thing you could find on her, how did your life change? And she had this very blissful life. She got married and she was doing great, and she had these anterior bridge work done, and like overnight her life went down the tubes. And she 3 or 4 months after that, she tried to kill herself. And David, you measured it, or you said, I think this is what your problem was?
Yeah, I didn't have a well, I didn't have a real true measuring device. I just, it was intuitive. It was stupid, but I did it, you know.
And instantly turned her right around. And I think that's where the brain function came in. It was a deterioration of it was the forelobe, the frontal lobe that was being depressed by the galvanism, and literally had turned her life down into a depressive state where she attempted to take her own life.
I really appreciate what Dieter said with that. I'm going to look at that aspect of it more closely. Phil?
The International Academy of Oral Medicine Toxicology is in the formative stage of a multi-centered study using brain mapping as a possible diagnostic tool to determine the changes in neurologic function of patients before and after amalgam removal. And hopefully by the next annual meeting in the fall of next year we'll have a report on it. EEG.
Question in the back.
Computerized EEG.
I'd like to make a statement. There should be a concern from the physical posture of the chewing mechanism, because we've done a study of 50 cases where we did EAB work, and we showed a 50% drop in the readings when we balanced out the jaw with, say, wax, which means that we change the electrical potential in that person, and that there is an overlapping of the physical and the chemical.
Yeah, the production of piezoelectric current just from chewing. Yeah. Yes?
From the standpoint of the fact that Ed's videoing and others are taping, can we do something about a mic for these comments? Some of these comments are excellent, but we're not going to have.
That's your ballgame, Ed. Any other questions? Thank you.
Let's see, we have 20 minutes after 10. We're scheduled to take a break at 10:30, so should we take a break? We'll take our break now and return at